I guess raise your hand or whatever if you can't hear me. It's good to be here. Um, this is a topic we've discussed before, I think, in another session within the last year or two, but I feel like it's an important one. Important because I think we're all involved in this to some degree or another, as part of our careers, as part of the jobs that we have, as people come and talk to us for recommendations or advice, to you all as the experts in your field, and for us to try and figure out, what do we do to help people. That's a really big role as far as our admissions department here. It's not just admissions, but also it's really kind of an intake and assessment. So people can come here, to kind of figure out what the next step might be. It may be admission to the hospital. It might not be. It may be, some other type of, referral to some service in the community, or it could be, to some subacute or outpatient type program that we have here. But the admissions department here is not limited to just admitting patients to the hospital. So we'll talk a little bit about that. Just as far as we're going through this, I've asked Joseph to please let me know if questions pops up, or if you have anything you'd like to add or comment on, or something to clarify or expound upon. Please let's do that. I'd love for it to be a discussion, and not just me talking. So what we're going to kind of talk about today is what kind of the levels of care are within mental health services, the type of intervention that we may provide, and then how you kind of assess for that level of care. It's not necessarily going to be step 1, 2, 3 in this. We're going to talk about a little bit of these elements within each kind of segment that we're talking about here today. So again, if you have questions as we kind of go through this, then let us know, and we'll try and use our time wisely. If we don't get through the whole discussion because we've had a lot of questions and discussion, then that's great. And then we'll still send out the slides. And then if anybody wants to talk about maybe some things that we didn't go in depth on, or if other question pops up, then feel free to reach out to me, and we can talk about it more. So just when we're looking at mental health services in the different roles that we have as mental health workers, we're kind of all over the place. We could be traditional outpatient, where you're seeing someone in your office a couple times a week, or maybe over Zoom a couple times a month. We're seeing people in schools, we're seeing people in hospitals, all different kind of areas where we're seeing people. But for this slide, I just want to kind of point out that only about, this is according to NAMI, but only about 43% of adults with a mental health issue or potential diagnosis actually seek help. So more people don't seek help that could use it than should. And then elevate that to the next level, that over 64% of adults that have a severe mental illness seek services. So those people that probably need it even more are not accessing that. With kids, adolescents, they are, probably the most likely to seek services at 51%, but that number's still really low. And with adolescents, I would feel, or my opinion on that is, it's probably that kids have more advocates around them than an adult might. They're going to have parents, teachers, school counselors, religious leaders, other people that may say, hey, I think you could really benefit from some help, or someone's going to that kid's parents and say, hey, I really think they could need some help, and then they have that better chance of accessing it. Just as far as demographics go, just for us to be aware that the white population are 20% more likely to seek services than people of other minority groups. I kind of throw these stats out there just because when people are coming to us for help, and when I say us, like mental health professionals are coming to us for help, is pretty significant because there's more people that aren't seeking help. And so I feel like it's our role to try and help them access the systems that provide mental health services. Because most of them, they know there's something going on. They don't know who to talk to. They don't know where to go. And so then they end up in an emergency room, or they end up in the school counselor's office, or they end up getting in trouble somewhere, and then they're like, well, where do I go? What do I do? And so when we do get that chance to meet with them face to face, it's pretty significant, because we are at that point maybe the person that helps them actually access services that can help them. So for us, it's important to really understand the different levels of care and what they are, so that we're referring those individuals to the right level of care where they're going to get the most help for their individual circumstance. And it may be you yourself that provides that help, but it may be that it's not what you're able to provide isn't fully what they need. And for us here in the hospital, it may be that they don't need hospitalization. It may be that they really would benefit more from another level of care outside of acute hospitalization to help them make progress. So as we get an understanding of what those levels of care are and how they can help a patient, it helps us to understand how to get them going in the right direction. So this is a summary. This is not all inclusive as far as what the levels of care are, but it's pretty, one being the less intense. If we're looking at what we hear in insurance terms or clinical terms as least restrictive environment, number one, traditional outpatient care, 2, IOP, partial hospitalization or day treatment, community integration, residential, subacute, acute psychiatric hospital care, and then acute care hospital, or kind of, we're going from one end of, the amount of supervision and intervention that's needed to all the way on the other end where there's real intensive. So we'll talk about a little bit about these levels of care, and when is the most appropriate, and what might be the next, when might it be the time to kind of move on to the next level. So when we talk about outpatient level of care, there's actually a level that's before this, if you want to call it 0, but it may be something like an AA group. It may be something like a parent support group. Some might even say it's like, self-help book or something like that, where some intervention is happening. And a lot of people benefit from that level of care, right? I mean, some people can educate themselves on what to do, and they're able to follow through with that and make the changes that they need to. Whether it's just from a support group or, again, something that they're kind of taking in information themselves. So when we're kind of looking at progressing through levels of care, we're trying to look at what is effective for that individual and what is helping facilitate the changes in their life or in their environment that help them get to a healthier place. And if it's self-help and they're able to kind of do that on their own, that's great. But when we get to this next step of kind of outpatient level of care, that's where something's come up in their life where they've kind of identified that they're not doing well, and they've sought out an outside person. It's not talking to a friend, it's not talking to a family member. It's progressed to the point where they're reaching out to a professional. So this is individual therapy. It could include like medication management from a psychiatrist. It could also be done by their primary care physician, their OBGYN, PA, APRN. But it's essentially where they're having kind of that weekly, monthly touch from a professional to try and help them get a plan together. So if you're the one, or if you're talking to someone and this is what they're doing, kind of want to finding out from them, is that helping? Are they making progress? If they're making progress, if they're able to set goals and accomplish those goals, or they're progressing towards their goals, then outpatient treatment is great. It may be what they need. As far as we look at this level of care, it may be also too that, if we're meeting with someone on an outpatient level, or someone of is meeting with someone on an outpatient level and it's not quite clicking, that level of care still might be the right level of care, but it might be that provider that they're seeing isn't trained on the area that they really need, or what they really need to be focusing on. So, if someone's seeing someone in a practice and they primarily deal with, anxiety, depression, but I've got someone that's, has eating disorder tendencies, then you probably need to look at making a referral over to, someone that has that eating disorder training, at least that sensitivity in that area. So as mental health professionals, as we're talking to people, we need to understand ourselves kind of what the scope of our expertise are, what the scope of what we're able to do, can handle, to make sure that we're not underserving that particular client or patient. And by extension, if we're working for an organization, then we need to kind of understand what the limits of our organization or the institution that we work for can provide. So if you're working in a school setting, then understanding, I can only provide so much to this student, during the course of a week, during the course of a month, because of everything else that's going on. So this, and again, that self-awareness is an important thing. So when we're looking at outpatient level of care, just kind of like when we would accept a referral for this, as as a mental health professional, this is when there's failure of maybe those self-help things that we were talking about just a little bit ago, or the individual starting to notice that there's an increase of maybe use of drugs or alcohol, or maybe even the starting of using drugs and alcohol is kind of an indication, that things are changing in the dynamics in that person's life that necessitates some type of outside intervention, even if it's just the outpatient level. It could be that things are starting to decompensate, in different areas of their life. Could be, school grades are slipping, it's harder to get them to school, there's more school refusal, there's missing of classes, there's missing of homework. If they're starting to notice that there's conflict with peers, or they're starting to isolate more, and same kind of things at work. If someone's starting to have more and more resentment about going to work, or they're having more sick days, or their performance is starting to slack, then that's when, at least we start looking at outpatient level of care. Important to note here that as we go through these levels of care, that we're always kind of in the back of our minds thinking about how safe that patient may be. Are they reasonably safe at home? And so, this person in an outpatient level of care, they're safe to be at home. They've got reasonable supports at home. Even if they're having some, kind of hopeless, helpless thoughts, possibly maybe even some suicidal ideation, but they're reasonably able to, safety plan at home, and again, have good support as they kind of go through treatment progression at this level of care. Any questions about outpatient level of care, or what other people may want to add to this? This is probably by far the most common level of care, across the state, across the country. This is what people usually think of when they think of mental health, as someone going to see a therapist or going to their doctor for medication. So this is really hopefully the place that people enter into, mental health care. And I think it's safe to say this would also include like the school counselor level or the level where we're seeing patients for the first time.
So John,
Yes.
Tina's asking in the chat, do you address exposure to porn among teens? And I think maybe Tina, you can clarify. I think you're just asking, is that in outpatient treatment that we would address something like this? Is that what you're asking?
So Tina, are you asking about that for us here at Aspen Grove, if this is something that we address?
So she gave a thumbs up.
Okay. As far as an acute type setting here, and we'll get into this a little bit more, in an acute type setting here, we would address that if it's contributory to the reason that they're here. We're going to take, as part of our assessment, we're going to look at, what an individual or a team may be involved in. If a teen is talking about exposure to porn or, viewing of porn, kind of depends on what's kind of surrounded with that. If that's happened and, there's a lot of guilt or there's a lot of shaming for that behavior, that's when we may see someone here, because it may cause them to feel suicidal or feel like they can't be at home. They may have been, found out, so to speak, and now they just don't know what to do. And so they end up at this level of care here. So yes, we're going to start to address that here in the hospital as far as, how do we get back to a state of mind where they've got the hope and the will to kind of move forward and kind of expanded their horizon. And we're trying to look at, well, okay, what is this about? But on the acute level, when someone's only here for about a week, maybe 2 weeks, there's a lot more work that goes around addressing that issue than we're able to address here on the acute level. And I don't know if that answers your question. Yes, we would look at it here on an inpatient basis, but admitting someone to a hospital for exposure to porn would not be something that we would do here specifically. I mean, if you're looking at someone that wants to get into addiction type treatment for porn, for alcohol, substance use, whatever else, that's more of a different level of care than we do here. So, okay, and if we need to come back to that question, we can. The next level that we're talking about here is intensive outpatient program. Intensive outpatient is where, as the name suggests, it's outpatient, more intensive because it's happening 3 or 4 times a week, usually 2 to 4 hours a week. It's typically really structured, so about a 6 to 10 week course. But there is not just one single definition about what an intensive outpatient is. Different programs have different modalities that they use. Different programs have different areas that they will focus on. Us here, we have an adult and an adolescent, kind of general mental health IOP program. Other people may have a program that's specific to substance abuse. For us here, we're looking at trying to focus on, their social skills, their problem-solving skills, how to improve their confidence. They're just kind of day-to-day function. How do we improve that? This is not terribly unlike what someone might be doing in individual therapy. They may be doing those same things in individual therapy, but where this is different is that, we're able to use at this level, and IOP in general, is we're able to use kind of the group dynamics to help kind of reinforce some of those concepts and some of those goals as someone goes through treatment. Patients, clients are able to learn from each other. patients are able to really kind of practice together those social skills in a supervised setting. Um, they go home and they practice them, and then they can come back and kind of report back on how they did and get feedback on maybe what they could have done differently, or reinforcement on really what did well. And then IOP is something that can actually be done in conjunction with outpatient, like general outpatient. Some IOP programs do have a built-in therapist that sees the patient as part of that program. But for example, ours here, we don't have that. So if someone wanted to come to our IOP program, and we're not the only one that does it this way, but they come to our IOP program to get that group dynamic benefit, the increased frequency of services, but then still go back and meet with their individual therapist. Because some of those individual issues are real specific to that person, right? And so it's not for the group to discuss those type of things necessarily. One person's trauma and how they're dealing with their specific relationships, they do need that specific coaching. So, IOP is something that does really well if it's done in conjunction with just kind of regular outpatient. At the same time, though, if someone is just really kind of struggling with, their social interaction, then IOP that few times a week can really help build that confidence in moving forward and how they address different things in their life. So it's really good. As far as like insurance companies go, they really like IOP. I know as far as like getting authorization or pre-authorization for IOP, they're usually like, good, we're going to give you 40 days. Call us. I mean, as far as what we do here, it's, they'll give us a huge chunk of days to do services. And then if it needs to go beyond that, then we'll seek the additional days. Again, that varies from insurance company to insurance company. But I guess what I'm saying is, if you're talking to someone about IOP, most insurances cover it, and it's not very difficult to get that authorized by them. So, when do you use IOP? This might be like we talked about kind of the decrease in or the worsening of performance in school, work, home, social, those different arenas of someone's life. If those are deteriorating, outpatient individual isn't quite cutting it. This is where IOP might be a good thing for people to try. And again, it sometimes, from the time I meet with the therapist today, and then I go home and I work on my things, and it's kind of in the forefront of my mind for the first day or two. And I get back to the therapy appointment, even next week, I might be saying, now, what were we working on again? And it's sometimes hard to keep that momentum. So if a patient's having a hard time keeping the momentum going, sometimes the increased frequency of services can really help things to try and move forward. Again, this is, as far as safety goes, this is someone that is willing to participate. This isn't the level of treatment that does well for someone to be compelled to do. I know with our adolescents, mom or dad might really want them to do, but people that are willing and kind of coming on their own to do it are going to get the most benefit from it.
Hey, John, Jill's asking what age groups we serve.
We have IOP for our adolescents is ages 12 and up, 12 to 17, and then 18 and up for our adults. And so you can remind me too if I'm wrong, but for adolescents is in the afternoon, goes from 4 to 7 o'clock at night. We do have a 10 to 1 for adults, and then I believe another 5 to 8 in the evenings for adults as well. So there's two options for adults, but for kids, it's generally after school time that they're here. Okay. Partial hospitalization, or sometimes called day treatment. This is the level of care where someone's getting a lot of the benefits from being in a hospital setting, but they're still able to go to bed in their own bed at home. And that's maybe an oversimplification, but it is intensive. It can be usually 5 days a week. It's usually 4 to 6, sometimes 8 hours a day. Again, it just kind of depends on that individual organization's program for partial hospitalization or day treatment. There's a lot of group involvement that goes on with IOP, a lot of group programming. Sometimes there's some experiential programming that happens depending on the program. That could be on-site, that could be off-site, where they're taking people to go and do things. With partial hospitalization, and again, not with every partial program, but there can be involvement from a prescriber that is going to meet with the patient to look at the use of medication or changing of medication to see if something of that might be indicated. Also, at this level of care, there likely is some individual therapy that's going on. One difference between this level and IOP and outpatient, general outpatient, is that people generally aren't seeing their own outpatient therapist while they're doing partial hospitalization. Part of that reason is just it's really intensive. Coming to partial program, it's almost like a part-time or full-time job for someone to come to treatment that many days a week for that many hours. Some insurances, just as far as the insurance side of it goes, because I know people will ask these questions when they're looking for referrals. Does my insurance cover it? Insurance companies get really hesitant, or they get a little bit, I don't know, kind of sets up a flag for them if they're getting billed for two different levels of service for the same day of service. So if you're going to partial today and you also inside your outpatient therapist today, then they may not approve both. They might, they have that discretion, but it depends on the policy. But some policies would say that you can't have two levels of care within the same day or on the same day of service. So it's a little bit tricky that way. So sometimes people will have to kind of make that decision on what's the best thing to do. And this level of care is, it's not as common in the States. As you kind of look around in the community where it is. We have one here that's for women. It's specific to women, but just like I was talking about with IOP, there are programs that are specific to general mental health, that may be specific for mental health, for maybe people that have thought disorders where they're needing more intensive treatment, day to day. Provides that structure for them. But it's a good option to try and help someone maybe avoid hospitalization. And it can also be a really good option to help people step down from hospitalization, where they've been in the hospital for a couple of weeks, they're still feeling somewhat fragile. Family has some concern about them being at home. So this level of care may be something that helps support both of those concerns, where they've got a good amount of supervision during the day. If something comes up during the day, then there's the partial program can make a referral for admission if that needs to happen, or they can definitely be talking to the patient and their family or whoever their support system may be to kind of look at, okay, let's see kind of what safety plan we need to look at, for this level of care. So these people that are in this level of care, when do they need this level of care? When we're looking at the amount of time that they're going to be in services, you have to look at where that time's coming from, and that helps kind of help us understand, if they need it. to explain that, it's if someone is not going to school because their anxiety or their depression is so bad, or they're not able to work, or they're not able to do the things they otherwise would do at home, then this might be the right level of care. If someone's concerned about losing their job because they're going to enter a program like this, what we might look at is, are they already in danger of losing their job because their performance is deteriorated that much, or they're missing that many days of work or school, that they're subject to either maybe losing their job or failing in school? Do they need to take a timeout to join a program like this, but still be able to be home? Because they maybe they don't need that 24/7 supervision. We'll talk about that in just a little bit. This is when we're looking at safety too, this is where it's because it's that high level need for supervision, we are constantly, as mental health professionals that are running this type of program, they're going to have to be looking at, is this someone that can go home at night and still be able to maintain well enough to get back the next day? And sometimes that going home piece and coming back is one of the most important elements of treatment, because hopefully whatever they're learning during the day gets taken home, it gets practiced, and then they come back. With partial hospitalization, for it to be effective for the patient is not that it's daycare. Excuse the term, but this isn't where someone is coming to day treatment so that their family doesn't have to attend to their needs during the day. They should be coming to day treatment to learn those things so they can be more independent, so they can be more effective at school, homework, wherever those other areas in their life are, so that they can then, perform in those areas that they want to. So again, it is treatment. This is not daycare, and this is not respite care. This is where people are trying to make progress and trying to heal and get to a point where they can be more functional. We talked about IOP, we talked about outpatient. This would be a step up from IOP, of course, with the intensity. So if someone's just really not progressing through the IOP system, then maybe they get bumped up. On the same level, if someone is just doing really, really well with partial, then the consideration may be, well, let's give this person some more freedom. Let's give them more opportunity to use those skills that they're learning. And the place where they're going to use those skills are back at home, school, and work. So transitioning them from a partial program down to an intensive outpatient program will give them opportunity to use those skills and practice those skills. So it's a good step up, step down system.
We have a question in the chat. Jill's she had a question, kind of a follow-up of the age group issue. So she's asking if you have any suggestions for younger clients where they can seek help. I know our population is from 12 to 17 for adolescents, but if someone's younger than that, where would you suggest someone start to look for services for someone like that?
Are we talking about 12 and younger, like
younger than 12, right?
Age. This is where I'm stumped a little bit.
Yeah, so 7 years to 12 years, maybe.
Yeah, I know there are some. I know University of Utah runs a couple of programs for partial hospitalization through what they call the KidStar program. And I believe Wasatch Canyons does as well as part of the Primary Children's Intermountain Healthcare system. But Joseph, that's maybe something we can ask Brianne too about. She may know about that. So
yeah, you bet.
Yeah, Jill, why don't we get back to you on that one too and see what we can find for you, get that information to you. We can
I'll make sure we follow up on that one, okay, Jill?
Okay. So these level of cares that we've talked about so far are generally available for the community at large. People that have commercial insurance that they get through work, your Intermount or Select Health, your United Healthcare, those type of insurances, etc. They're going to be usually have some type of coverage for outpatient, IOP, and partial hospitalization. This next level of care, community integration or extended care program, this may be more exclusive to people that are on Medicaid, where they may have, be on disability because of their mental illness. They have that designation, or it may be someone that might be on commitment, that's been committed through, mental health. They may be on a civil commitment. They may be ordered to this type of level of programming. These type of programs are generally run by the community mental health centers. That would be, in our area, that would be like Wasatch Behavioral Health. And this is like partial hospitalization plus everything else that may be going on in their lives. They are still living at home for the most part, but they may be in some type of supported housing where they have people that are coming in to visit them. They may have like a clubhouse setting where the person can come in, and that's where they can just be during the day to socialize or to participate in activities. There could be an element of vocational training where they are working, but they're having follow-up support, or there's a job coach that may be involved. These are really robust, cost-intensive services that, again, are usually run by the state, and not everywhere in the state are these available. It sounds like a really nice idea, but there's the availability of this type of level of care is pretty limited. We do have more receiving centers and kind of drop-in centers around the state. Wasatch Behavioral has a receiving center, and so kind of what a receiving center is it's kind of a crisis stay place where someone may go for a few hours. That might be a 23-hour kind of thing, where they don't necessarily need hospitalization, but home may not be the best place for them right now. For adolescents, this could be somewhere like Vantage Point, where they can go. In Salt Lake County, it's the Youth Receiving Center, where they can go, and it's kind of a 23-hour timeout where there's support there, someone to talk to, gives them a break to be away from whatever stressors they may be being hit with directly right at that moment. But and more of those are popping up. They are a good option for someone that may be trying to avoid hospitalization. That receiving center in and of itself is not like an ongoing treatment provider. It's not like you see your therapist there every week or every month, but it is a resource, and it's a resource that sometimes may be included in the whole wraparound package that these community integration programs have. So again, this is something that may not generally be available to the public, but these are services that are really tailored to those people that may be diagnosed with those severe and persistent mental illnesses like schizophrenia in particular, that just really are debilitating and need those extra services. So again, lots of services, not a whole lot of availability. Residential level of care. This one kind of insert a little bit more in between residential level of care. I'm going to talk about next as far as hospitalization. Residential care is where someone is going to live. So with this level of care, we don't have the opportunity to go to work. We don't have the opportunity to go to school in the traditional sense, or be home with our families or loved ones or whatever else. Maybe we are men, if you're in a residential setting, that's a facility that's taking care of all of those basic needs of life. It's where your shelter is, it's where your food is, um, it's where your medical care may be provided or arranged for while you're living there. It's typically something that's 30 days or longer. Um, this is, these are pretty basic, but this is things that adolescents may be involved in. Definitely like the rehab level of care for substance abuse is what this is. This is where the focus is going to be looking at, addressing behaviors, changing behaviors, because those behaviors haven't been safe or they've been so destructive that you need to be somewhere where you're not able to do those things that hurt you or your livelihood or your families, either physically, emotionally, financially. There needs to be a timeout, extended timeout, so to speak, so that these different areas can be addressed. So, if you think about this, if you're talking to someone in an outpatient setting, all of those other ones that we've talked about, where they are still continuing to get in trouble at home. If it's an adolescent, they're continuing to get in trouble with the law. They're continuing to just be extremely disruptive at school if they're facing things like suspension from school, or if someone is being fired from their job because of their substance abuse, family is about ready to kick them to the curb, so to speak, then that's when we're looking at this level of care, residential, where kind of everything is kind of provided in that one place, taking them out of those environments where they've been destructive or self-destructive, and then they can now get the treatment that they need to try and help themselves move forward. So again, like we're talking about here, we're talking about severe inability to function at school, homework, and they need to be rescued from themselves to get the help that they need. And again, this is about trying to address their behaviors. It's trying to address their thinking patterns, their behavior patterns, help them get some new insight, develop some new habits. And we all know habits and thinking skills, those all need some practice. So the residential level is where we give a chance for those individuals to practice those behaviors. Those other levels of care, we're saying go home, practice those, with your family, practice those at school, work, wherever it may be, and then come back and let's talk about how it went. But residential, we're saying, here's these new skills, you practice it within this setting, and then we'll talk about how you're going to keep those things going forward when you get home. So typically a residential level of care is coming up when the lower levels of care, those other less restrictive levels of care, have not been successful. We've tried outpatient, we've tried IOP, we've tried partial, behavior continues to worsen, or it may improve slightly, but there's still a significant disruption, like severe disruption of those different areas of life. So this is a level of care, of course, very expensive. Not all insurances cover it, but very expensive because it is so inclusive. I mean, we're talking about the person who's living there, eating there, sleeping there, getting all of their treatment within that setting. And so it demands a lot of resource, so it demands a lot of money. So if a family is talking about going into this level of care, but they haven't tried those other levels, for some people that financial piece can be make or break. So it's, but at the same time, those other levels of care, if they haven't been tried, they can be just as effective as residential. There's no magic bullet to locking someone up in a residential that they're going to be guaranteed to get better. So it's tricky that way.
So before we move on, there's a question here in the chat. Someone's asking, is there a list of facilities and who they serve and entrance requirements available for residential care?
there are a lot of residential services, and there's a lot of different clientele. Joseph, maybe this is something you could get with Brianna and send out too.
Yeah,
Residential level of care, if we're just, just for example, if we're talking about adolescents, there are all different kind of levels and maybe what they focus on. So there's residential facilities that are, that are locked down, and they're the places that have the brick wall around the perimeter. So those patients they don't ever leave unless it's some special event, but that's where they stay. There are other residential type facilities where you may not realize it, but it could be a home just in a neighborhood where um, the kids are staying there, and there's house parents there, and there's people that are there that are helping them with their day-to-day kind of living and learning how to do things. Um, that kind of open model, more open campus model suits some people. For other people, not so much. Um, so different places do have different criteria. Um, there's a lot of residential places in Utah. Utah's very residential friendly as far as the laws go. But Joseph, maybe that's a list we can send out too. I know Brianne's part of you're our business development director, and we've done a lot of work with residential teams. So
yeah, definitely. We'll get together with Brian and talk about that. One other question, someone, let's see, Jessica is asking, also wondering if there's a list of day treatment and IOP programs in the area. So yeah, it sounds like maybe she's more interested in like, do we have like a directory of, facilities or something like that? That is a good question.
yeah, and that's a good resource. Maybe we can work on that too. Um, it's a bit tricky because not every place is covered by every insurance. So if someone calls their insurance team, they would be able to provide a list specific to that insurance. But for the purposes of this group, what I'm kind of hearing is it might be useful to have a list of places that just you might be able to give family members or whoever, a list at least to start with.
That's a good point. Yeah. I mean, so that we don't, waste our time calling facilities that we can't, that don't work with our insurance. Yeah. Great.
Well, and what I found too, though, is if someone was to call residential facility A, and you kind of present, this is what I'm working with, this is the kind of client I have, this is maybe what they need, and they say, well, that's really not us, they usually are able to give a referral or a recommendation as to what other residential facility in the community might be a good option for that individual. So, I mean, it's a pretty small world when it comes to the residential facilities, especially when we're talking about substance abuse rehab. They all have a pretty good awareness of each other and what they do. So I think that's good to know. So
Yeah, Shalise is saying it would be helpful to know which ones have a free evaluation and consultation 24/7. I know our hospital does. We have free evaluations 24/7.
yeah.
You can even walk in.
Right. And that's what we were kind of talking about here. As an admissions and assessment department, we would be talking to people about maybe what that next best step is for someone. Most facilities are going to want to do their own intake assessment as far as, does it meet the criteria? So we're happy to talk to people about, what their options may be. But if someone's feeling like they don't really know where to start, then we definitely want to talk to them, especially if it's an issue of safety. If someone's wondering whether or not they feel like they can be safe, then we want to talk to them for sure. Which kind of brings us to the kind of last level of care, which is acute hospitalization. Typically hospitalization is at least 3 days, typically closer to 5 or 10. The goal of hospitalization is to keep someone safe because they are not able to do that on an outpatient basis. Could be that they're not safe because they're suicidal. It could be because they're not safe because they may be psychotic to a point where they're not able to function and they're putting themselves in danger. And that, in my opinion, that would include someone that is experiencing mania. They may not be homicidal, they may not be suicidal, but if they're putting their livelihood in danger or the lives of their loved ones in danger because they're out spending all the money, or they're out having random sexual relationships, that is in my opinion destructive enough to warrant admission to the hospital. So we we're if someone is not able to be safe, that's what we're going to be assessing for, is are they really putting themselves in danger to a point where they can't be managed on an outpatient basis. And that's when we would look to have someone in their care. But again, we're always willing to to talk to someone, or if someone wants to come in and meet with us, we can do that and kind of figure out where that next step is. Traditionally, people go to an emergency room to access hospital level of care. That doesn't necessarily need to be the case. Some people that may be suicidal and they tell a family member or a loved one they're having those type of thoughts and they don't know what to do. Yes, you can go to the emergency room, but you can come to somewhere like here as well, where we can do that assessment to see if hospitalization is needed. We don't charge for that. We just want to help them get the right place. If they need hospitalization, we can help them with that here, then good. If not, then we would try and make that referral elsewhere as well. So again, it's about trying to help people access those services. So Joseph, I know it looks like we're running out of time. We'll fly through these, but then you're going to get these slides, and then again, if you have other questions, just let us know. So again, the goal of hospitalization is to keep them safe, help them stabilize, and then return back to other services maybe that they were in, or helping them set up those services, med management, therapy, whichever it may be. So they're getting back. So the hospital, being in the hospital, of course, doesn't cure everything that the patient's experiencing. It's just getting them back to a point where those lower, less intense level of care can be effective. That maybe the highest level is acute care medical hospitalization, because that's where something's happened where we can't really even start to do the mental health piece because of the medical condition that they're in. This could be, a really severe overdose or some type of self-harm that's necessitates that the medical issue be addressed before the psychiatric or the mental health issues can be addressed. And this is in part why sometimes people do need to go to the emergency room first, to make sure that they are medically safe enough to be in a psychiatric setting. And because there's a lot of different things that can cause what may look like psychosis. And if someone is overdosed, I can't, if your liver's having problems, all the therapy in the world's not going to fix that issue, right? So, we need to let the medical piece be addressed as well. So, talk about that. As far as, and this is just kind of maybe one last thing here, is when we're looking at transitioning someone from one level of care to another, up or down, in any directions, there's a need to really have a good understanding of the patient themselves, but also the environment that they talk to, what their support is within that environment. We may need to have someone that be admitted to the hospital because they simply don't have the support structure at home to help support outpatient accessing services. We may not need to admit someone to the hospital, even if they may have some suicidal ideation, because they do have good support, they do have good engagement with their treatment providers, and they're able to still function on that outpatient level. But at any time if those things kind of fall apart, then you need to seek a vision for a patient, either here or to the ER or somewhere else. We just want to make sure that their safety is kind of paramount as we're looking through all these levels. So there's just the last few slides are just some tools that you can use for determining level of care, what that might look like as you're meeting with the patient. So some more formalized kind of assessment tools that you can use. So not to keep you long any longer, but sounds like Joseph and I will be working on getting some resources out to the group, and then we'll send my email out in that note and that as well. So if anyone has any questions, I'm willing to talk to them about whatever it may be. So appreciate the time talking to you all, and I hope this was helpful. And again, if there's anything that I can do to help any of you as you kind of interact with the clients that you're seeing, please just let me know.
Great, thank you, John. Yeah, we appreciate your time. So I did drop the evaluation in the chat. I'm going to do it one more time here. I will give you a link to the evaluation. Especially if you want the slides, please fill out the evaluation. That tells me that you either want the slides or the certificate or both, and I'll be sending those out. So shoot your email, do your evaluation. There's a class code. I dropped that into the chat as well. And if you run into any issues accessing the evaluation, just reach out to me. I gave you my email here in the chat. It's joseph.turk@uhsinc.com. Just reach out to me. I understand sometimes, our company's firewalls can be kind of a hassle, and that's okay. We'll figure out a way to work around that. If you need to forward the link to your personal email, or you need me to shoot that to your personal email, I'm happy to do so as well. And then check out our YouTube channel. We have most all of our courses up for review there on our channel. So if you want to go back and maybe review some of the things that we discussed today, please do. I usually have the current video up at the end of the week or so. So maybe look around Friday or maybe Monday just to be safe. I'll have this class uploaded there as well. So we did have just really quick one other question. It looks like Lisa had previously asked, how would we answer questions about the situation in Maine where the shooter was released from the hospital? I don't know. What do you think, John? I mean, it sounds like that was kind of a situation where maybe the hospital was very hasteful to release the patient, and I don't know really what was going through their mind at that point. Maybe there were indicators that that weren't flagged. I really don't know. How would you address something like that?
And that's kind of tricky. I mean, I don't want to be too presumptive or hasty to judge what the hospital did or didn't do. I mean, I think we all know we're not mind readers. We can get some sense of maybe what's best for a patient or where they're at. But we can't 100% predict what someone is going to do. I know we try and err on the side of safety. So that's tricky. It's tricky to say what the hospital could have done or what that facility could have done. Hindsight's 2020. As far as what we would tell maybe the patients that we see, or their family members that we're talking to is, if there's a concern, reach out to someone for help. That could be reaching out to, calling us here as an intake department. It could be reaching out to like Wasatch Behavioral's mobile crisis outreach team. It could be, if needed, calling 911. If there's an immediate concern and indicate that it's a mental health issue, and there are police officers that are trained in handling mental health situations. So hopefully one of them could respond to that type of need. So, kind of goes back to that, we all have to keep our eyes and ears open and then act and make that referral if we can. And even if we don't have access to that patient directly, we help the people that are around that know how to access those. those supports through the police or the hospital like us here, or other mental health resources. So hopefully it doesn't escalate to that point. Well, I don't know if that helps. I mean, those situations are always, of course, really sad, and I don't think there's anybody that could have done something wishes they didn't do more if they could have.
Great. Yeah. So we do hold these courses every second, and well, we try to hold them every second and fourth Tuesday of the month. So I know we had a question, how often are these courses? So yeah, if you want to join us again, we have one scheduled for the 28th already. So I'll be shooting out an email shortly for that. And yeah, please share the email with your friends, or tell your friends about it as well. I mean, a lot of times, even if someone doesn't need CE credit, these are great resources for, dealing with these types of issues. And, we really cover the whole gamut of mental health in one way or another. So please do share this information with others, and we welcome that. Did anyone have any other questions for John before we let him go?
Can I just add one more plug?
Yeah, please do.
If you or your organization, as you guys are watching these, if you feel like you have a topic that you would like to share with this group, it's a pretty big group that's coming. So if there's something that you would like to help the community know about, a topic or what your agency does, please reach out to Joseph, and we can get you on the schedule too to present as well. We'd love to hear from other people in the community about what their areas of expertise are and what they are offering to the community.
Great, thanks, John. Yeah, any other questions before we end today?
Hello, this is Jolene. I am not able to access the messaging that you're saying you put the link in. I'm just wondering if you can email the evaluation.
You bet, yeah.
Okay.
Do you have my email address?
I do, yeah.
Yeah, please reach out to me, and I'll just shoot the...
Send it to me. Okay.
Yeah.
Perfect. Thank you so much.
Yeah, no problem. All right. Well, I think that's it. Again, I want to thank John for his time, and I want to thank all of you for your participation today. We had some really good discussions going on, so I appreciate that. All right, and hopefully I see you all again on the 28th. Watch for an email. I should be sending that out shortly.
Great. Thanks, Joseph.
Thank you, John.